Hello, everybody. I think we're going to get started. Hello, friends. Hello. Hi. Hello. Good afternoon, everyone. How's everyone doing? Good. Great. And we have people online. Brittany? Yes. Hello, everyone. Thanks for joining us this afternoon. I'm Linda Montgomery, our Vice Chair of Education for the DFM, for those who don't know me. I have this, welcome to the meeting. I have a great pleasure of introducing our speakers today. Myra could not be with us, so I'm going to be sort of your leader here this afternoon. Um, First of all, I wanted to say, please remember that this is being recorded. We always like people to remember that. You will be able to access this recording again if you need to. And then please take some time to fill out the survey. I know we get so many surveys. Our great communications team read everything you say, right, Liz and Brittany? Yes, absolutely. So it would be great to get more ideas, any kind of feedback about anything from the food to the room to the speakers, suggestions for other speakers. We would love to hear it all. Everything is read, so please do fill out your survey. So today we are going to be hearing from 4 people I know really well. So I could just say they're wonderful graduates of our residency, and we'd love to hear them talk today. But I'm going to give you a little more detail than that. It's been really fun for me to be able to see what they've been up to since they left residency. So we're going to be hearing from Lauren Bull and Jess Jaw, both physicians with Denver Health. And they are the faculty leads for the Global and Immigrant Health Concentration at the University of Colorado Family Medicine Residency. We'll also be hearing from Nick Kaufman and Johanna Thompson-Westra, also family physicians, recent residents who are here to share their experiences from their 1-month rotation in Guatemala. A little bit more about our speakers. So Dr. Bull, besides running the concentration, is a faculty member. Which clinic are you at? Westwood. And she is an assistant professor with our Department of Family Medicine and the medical director of the Denver International Rescue Committee's Survivor Torture Program. So proud of you. And then Dr. Jha is an assistant professor of family medicine with CU, and she's a full-time clinician at Denver Health. Thank you for that, Jess. At Lowry. She's also the assistant director of the Clinical Readiness Program for Colorado Works for International Physicians, the COWIP program, which helps newcomer physicians regain careers in family medicine. And she has a special interest in global health, decolonization, and indigenous justice in global health. And then Dr. Nick Kaufman. Hi, Nick. He is currently a fellow in our hospice and palliative medicine program. He also is the persistent leader of our Health Staff Association. So he did that last year. I didn't know you could keep doing that. Apparently you can, right? So he is doing it for a 2nd year and leading that great effort for our House Staff Association. And then Dr. Johanna Thompson-Westra is here. Thank you for being here with us. And she is a family physician currently practicing at Denver Health. She provides outpatient care at Southwest Pena Clinic and works in labor and delivery at DH. She's passionate about maternal health, quality improvement, improving healthcare access for underserved communities. I'm really honored to have these 4 speakers here, so thank you for being with us. I'll let you take it over.
Great, thank you, Linda. And thank you again for having us. Can you hear me okay? Okay, perfect. So we just wanted to share a little bit about the background of the Global and Immigrant Health Concentration Linda mentioned, that we worked to start together to really provide kind of more of a wraparound support and structure to global health education for our residents who were thinking about going on an international rotation, such as the Guatemala offering. And so this really started when I was a global health fellow here at CU in the Center for Global Health in the fall of 2021, thinking about, and Jess and I had conversations previously when we were residents, feeling like when we talked about global health things, we had a lot of offerings around immigrant, refugee, newcomer health topics, especially at the Lowry Clinic, but really didn't have a lot of structure around true like international global health and didactics on that or other structure around international rotations. And it felt like a need of our program and one that we were hoping we might be able to meet. So I had sent out a needs assessment survey in the fall of 2021 to our residents and faculty, and turns out some other folks agreed with us. The majority of respondents felt like this was a need as well. I was able to use that information as well as some time during my fellowship to create a curricular outline and take that to Linda and Corey in the department and advocate for this to get funded and started. And many thanks to them and the department for saying yes to that effort. So we were able to start in the fall of 2022. The curriculum is 24 months. The rationale being that if you don't join it your first year, there's still time to cover all the topics during the 3-year residency. We meet every other evening, or excuse me, every other month. That'd be a lot. Every other month with a evening session. We actually just had one last night. So it's about 6 per year plus a kickoff introduction meeting. And that does equal out to 12 kind of main curricular topics we're trying to cover. And then there is some evidence for global health tracks in education and how they improve kind of cost-conscious care, cultural humility, et cetera. So a lot of benefits to our trainees. And all of that, of course, is important, but really what was behind this and what led Jess and myself to really want to start this program or this concentration is thinking about the ethics of global health, thinking about the topics of things like global health decolonization, and honestly being really self-reflective and having a kind of critical lens directed back on ourselves about this idea of the white savior industrial complex. Not sure if people are familiar with that. I know it sounds a bit heavy, and it in a way has nothing to do with race. It's more about people from a Western setting thinking like, oh, I'm going to go somewhere else and then quote unquote save them or help them without being from that context or having greater understanding of the true needs there. And I think you can hear there's quite a bit of inherent hubris we might have, even if well-intentioned in that mindset. And so really trying to push ourselves and push our residents to think critically about these things. And we like this quote from the author Teju Cole that says, if we're going to interfere in the lives of others, a little due diligence is a minimum requirement. And so really we wanted to ask our residents and ourselves to do that, little bit of due diligence and give them more structure around global health education before they go up potentially abroad on a rotation. So basically, we did work to recruit faculty. Dr. Zhao was kind enough to join me. Dr. Sarah Foster Fabiano, who many of you probably know, who also unfortunately moved away to North Carolina last summer. But both of them joined me to try to advocate to get this going. And in the fall of 2022, we were able to start the concentration. For anyone who's curious, that's a QR code that you can scan to see our kind of recruitment flyer. We are going to show a couple of pictures of it on the next few slides, though. And then for our curriculum, again, a lot of different topics, covering things like ultrasound skills, infectious disease topics, and non-communicable diseases globally. But the underpinning that we really want to focus on are these themes of power and privilege, decolonization, and a lot of that self-reflection as well. And some of the partnerships that we've worked to really strengthen are through the CU Center for Global Health. So Dr. Lisa Umphrey there in particular, if some of you know her, she's a pediatrician. Also with the CU Pediatrics Global Health Pathway, they've been really helpful sharing a lot of their resources and information. And then of course the clinic in Guatemala, the CU clinic there, that's called the Fun Salud Clinic that Nick and Johanna will be speaking about more today. And then one of our goals too was to really make sure we had an English-speaking site. The Guatemala clinic appropriately has a Spanish proficiency requirement to go there. And so recognizing not all of our residents are proficient in Spanish, trying to make sure we were able to set up a longitudinal partnership with a more English-speaking site. And Dr. Umphrey from PEDS does have a connection with this site in Uganda and something called the Atlas program. And so we've been working really hard on getting that set up, and we're able to finalize that this year. And one of the last things I wanted to mention is that there are a lot of efforts going on kind of GME wide on campus to get all of us together from surgery, ENT, family med, peds, and make sure that we are forming a more cohesive sense of what does it mean to be involved in global health as a CU GME resident. So there's a multi-department global health curriculum working group happening, and Dr. Umphrey is at the lead of that. We've been working for about a year and a half now on developing a curriculum for GME wide. It's pretty robust. We're just in the steps of finalizing it and are hoping to be able to publish that. There's also some joint pre-departure trainings happening. The goal of that being that if you're a CU resident going abroad that year, that you're required to do one of those trainings. And then something called the Global Health Foundations Day that Jess actually presented at last year.
So I'm just going to share a little bit about the nuts and bolts of our curriculum, but kind of a big picture overview. This is a page from the flyer that we have for recruitment for residents, and we try to share as early as possible in their residency experience. So the general idea is that this curriculum is here to support any residents who may have an inkling and interest in global health, and it may be in an international setting or may even be in a domestic setting. It could be with a focus around immigrant refugee health, or also an interest in indigenous health with like an indigenous nation here within the United States. The goals that we have explicitly stated for our program, first and foremost, to train and prepare residents to both complete an international or global experience during residency, and then also to prepare them in their careers in the future, if that is a passion that they hope to continue to explore. Second, to make sure that we are really emphasizing these themes around power and privilege and decolonization, and so that we're really encouraging ongoing critical reflection among the learners, and to really encourage this habit lifelong. And then lastly, I think just a broad goal of developing knowledge and skills around providing care in resource-denied settings, whether it's global or even here domestically. We have some requirements listed here. I'm just going to go through some of the kind of highlights. First of all, we want to make sure everybody who formally joins our concentration are assigned a mentor, a faculty mentor, to support them over the course of their educational journey. We also have certain requirements for how many sessions in the evenings we hope folks to be able to attend. And then, of course, we do expect one of their electives over the course of residency to be some sort of global related elective. The work that we are asking residents to do, a big bulk of that comes in the form of this pre-departure site profile, which the next slide will go into a little bit more. And then ultimately over the course of the concentration, residents will gather kind of a portfolio of their work within global health. So if you're interested, the QR code here actually will pull up the form that residents will fill out. And it's a 3-part piece of work. So there are things that we ask them to do research on before leaving. And then in the middle of their rotation, there are some ongoing reflections that we ask them to participate in. And then after coming back, there's sort of a debrief post-rotation essay. Also, Lauren was already mentioning some of the partnerships that we have already been able to utilize or are building. We actually were sending a resident to Uganda for this new site, but unfortunately because of an Ebola outbreak, we had to cancel that last minute, but I don't think that will change the future possibilities, more of a circumstantial complication. And we've actually built some new partnerships with IHS sites too, and so hopefully we'll be sending a resident as a formal part of this curriculum to Navajo Nation next year.
And just briefly wanted to share some of our kind of statistics so far for the concentration. So thus far, we've had 23 unique different residents participate in our meetings from our program. this says 16. We actually had a meeting last night, so 17 total meetings thus far that have been held. And then we have our 2 residents here today, now graduates, of course, who completed the concentration last year and went to Guatemala last year, and of course, are here to tell you about that today. And then, as just mentioned, one resident, Dr. Ali Cottrell, who was supposed to be in Uganda this year, worked incredibly hard to get that all set up and really kind of champion that rotation offering. And then the Ebola outbreak had other plans. And so she unfortunately is still here in Colorado instead of being in Uganda right now. But we're really hopeful that another resident will be able to go there soon. And then she will also complete the concentration this summer. All right. So I'm going to have Dr. Kaufman and Dr. Thompson-Westra come up and share a little bit more with you about the Guatemala clinic.
Great. Yeah, sure. Great. So we're going to be talking about first some information about the country of Guatemala for some background information, and then more into specifically what we did when we were there. And so these are some of the profile sources that we use to get some of the information coming up. And so there's a little bit of background of information on Guatemala. It's a pretty large rural population, and that was predominantly the patients that we were serving. We'll have more maps about like where we were specifically. Very large indigenous population, a lot of mestizo and Mayan like people living in Guatemala. Spanish is the majority, like the language of the majority in Guatemala. And so obviously speaking Spanish is a big plus to be able to go to Guatemala there. Not a lot of people were speaking English on the site. The quetzal is the currency there, local currency. That's the conversion rate. Relatively low per capita income, developing country, and we definitely saw evidence of that on the site with all the health issues that come along with that, and it's a constitutional democratic republic. For the population, so this is from 2000 to 2023, so was a pretty young population at the turn of the millennium, and now it is becoming less so that, but still a relatively young population. It's just the demographics there.
Yeah, and so in terms of health outcomes, Nick kind of touched on this, but the like teen birth rate is quite high. That is part of why the population age is quite young. Similar causes of adult death to here in terms of like heart disease, cancer, things like that. However, they do have quite a large burden of illness in children in terms of infectious disease, malnutrition. Similarly, perinatal mortality is quite high. There's just some stats about maternal death and neonatal death as well. Here, just kind of some indicators for health. So kind of looking at the adolescent fertility rate there in the middle, 61.8 births per 1,000 women between 15 and 19. Looking at the out-of-pocket expenditure for the GDP, family planning, and infant mortality rate is 18.8 out of 1,000 births.
Yeah. You can see also the life expectancy on the bottom left. You can see the country was pretty heavily hit by COVID as well, with the the decrease there around 2020. Overall rising population just in general. Dengue has its peaks and valleys. It seemed like we were in a peak when we were there. A lot of people with dengue, so we get to learn a lot about dengue that I didn't know much about practicing medicine here.
Yeah, this is just another look. WHO has some really neat graphs, and we got to kind of explore a lot of great information through the concentration, both before we left and after our rotation, just kind of exploring more of this. So kind of just looking at non-communicable diseases, and then like Nick mentioned, communicable diseases, especially mosquito-borne, are quite high given the climate there.
Yeah.
Again, just kind of some more graphs about infant and maternal mortality. It is fortunately decreasing, but still quite high compared to.
In the medical system, it was really great to be a part of the rotation we weren't really expecting was to learn more about just like medical training in general in Guatemala, being able to visits like the regional hospital that was near us to be able to see, you know, like how they practice medicine there, like what their medical training looks like. And so they also have four-year medical school. They do have a year, like basically an intern year of like being supervised in the regional hospital in Coatepec. It was like the nearest one to us. About one physician per 1,000 people, two nurses per 1,000 people. And so definitely a need there. And then they also have this like pretty robust community health worker program in, you know, in just the Americas in general. You know, with a lot of the population being rural in Guatemala, having the, you know, like a lot of education and healthcare being brought to patients rather than them having to come to clinic was a really valuable resource. And I think it's like a really robust program that's being able to be offered to people in Guatemala. And the different health sectors, there's like the public, private, and nonprofit as well in terms of like who is providing healthcare in Guatemala.
Yeah, and as part of our rotation, we worked with a she was a resident,
Mhm.
right? Yeah, a resident who was working at our clinic. And I think as part of everyone's training, they have to do a full year or 6 months. I can't remember.
Like 6 months. Yeah.
6 month at a rural site, like everybody does. So it was pretty interesting to just kind of learn that that was a requirement. Again, like the previous slide showed, like Guatemala has quite a rural population and is quite a rural country. So, you know, the need is there, and that's something that they definitely prioritize.
Also, family medicine doesn't really exist in Guatemala, which is shocking because like how like helpful we were there. You know, like the like internal medicine was like very common. There was a pediatrician who worked at the clinic as well. But we were like talking with the interns that are like the residents in the hospital, and they were describing like what it is that we can do in family medicine, and they were just floored at the idea that we're able to see all these different people and do all these different things. And you know, especially in a country where, you know, like in like a rural setting, like family medicine would obviously be really valuable. And so, yeah, I'm hoping that, you know, that is brought to that, you know, to Guatemala eventually, because that would obviously be an invaluable resource. Yeah. They're great. They're working on starting it. Great. Yeah. And then this is like the healthcare expenditures, like predicted from, you know, from a couple of years ago to 2050. The out-of-pocket spending hopefully is not going to change all that much in the next couple decades, but really hoping for government health spending to increase to be able to offset some of the needs that the population has. So that is the hope. Great.
All right, now's my fun pictures.
So yeah, this is the actual, so us getting there. So we flew into like Guatemala City as the capital city of Guatemala. Really beautiful. It was like a really wonderful experience to be able to hang out there for a little bit before traveling to like the complete like opposite end of the country for the actual clinic. And so like they have this like really lovely kind of like a strip with like this like nice bike lane. There's a bunch of like parks and outdoor areas. Also a lot of just like local like spending, like, you know, to have good green spaces for the people in the city. Different like municipal buildings that were really beautiful. And there's like the Reform District as well for more like the like just cultural aspects that were very like publicly available to the people there.
Yeah, definitely pretty like cosmopolitan, Western, what you'd expect. People like going out jogging and walking their dogs and things like that, which was definitely a contrast to then when we went out to our rural sites. So the star down there is our rural site. The like kind of area is called like Trafinio. It's in southwestern Guatemala, so close to the border of Mexico and close to the Pacific Ocean there. And so they kind of talked about it a little bit, but it's this like private-public partnership on the next slide between the CU Center for Global Health, the Children's Hospital here, and Agro-America. And basically the community there is, you know, quite underserved. It's a very rural area. Depending on traffic and road conditions, it can take anywhere from 5 to 9 hours to get there from the capital.
We experienced both. Yeah,
Yeah.
5 and 9 hours. Yeah.
And yeah, the highway that went out there we learned was only recently paved within the last 4 years, I think, for that it was a dirt highway. So yeah, quite rural. But this partnership has really kind of blossomed and helped this area in terms of bringing services that we'll kind of talk about more. And these are just, I like got this from the corporate website, but it's in fact about the number of people that they've treated so far.
Really like robust community there, like working on the like the plantation. And you know, like not only the plantation workers, but also their family, and being able to get really valuable resource, you know, just like medical care and resources through the clinic that we'll touch on, like specifically what they were getting. But a lot of people served in the, you know, 10-ish years that they've existed. And so this is the site. Shown is it's called the casita, where we were like living. There's like a kitchen in there. We'll have some pictures of that as well, and just like all the banana trees like all over the place that you can see.
Yeah, so it's on a banana plantation. That is kind of like you have to go through a gate with guards, and then you have to like just walking in, walking out. You have to like go through like an antifungal thing to make sure you're not tracking anything in or out through the site. But that is where the clinic is, the dorm where we stay. And like Nick said, majority of the patients treated there are workers on the plantation, but also in the local community, like the village that's right outside. So those are banana trees in case you can't recognize them.
Penny.
Yeah, it's very hot, very jungle.
Humid, yeah. More banana trees. It's kind of the theme. You'll notice throughout the slides. And so yeah, let's go on the top left picture. Like that is just all banana trees for like as far as you can see. The top right picture is a picture of the clinic from the outside. This is the side where the patients and the families would be able to walk up to like the front desk to be seen there. You know, some people would have appointments. A lot of people would show up, you know, like walk-in appointments as well. So, a few people had appointments and a lot of walk-ins. Yeah. And then there's like aerial views of it. Very open. So like the bottom right picture, like an open concept. Basically, the rooms are like the actual patient exam rooms are indoors. But so there's like really like nice green space where, in theory, there is breeze flowing through to cool you down. That is not always the case. But yeah, it's a very interesting clinic. Like I've never worked in a clinic that's like has an outdoor space, and it's very unique in that way.
Yeah, and kind of getting a sense from the bottom left picture, you know, we had our dorm, and then the kind of outbuilding with the 4 structures is the clinic. There's also a pharmacy there, the waiting area. And then the other 2 structures, they have like a clinical laboratory where they could run all the samples for patients there same day. Then they also have a basic science laboratory where they do a lot of research on things like dengue, other mosquito-borne viruses. And so part of that whole host of that kind of like clinical and basic science staff. And so, yeah, air conditioning isn't super common. So part of, you know, that like open concept just to try to get air circulating, just fans around, but that's sort of like the lay of the land.
Fun ambulance we got to ride in. Yeah. So they're able to transport, like if there is a medical emergency, able to transport patients from the clinic to the regional hospital, which we'll have some information about like how far away that is. In the kind of the background of the ambulance, there are a couple tuk-tuks. They're like these, I don't know, like moped style.
Golf cart sort of thing.
Yeah, that like a lot of the community health workers would use to like travel into the area to be able to visit families to provide those services to them. So those were fun to ride as well. And then these 2 gringos on the bottom right, and they're like they're going to back.
CU, our university greens.
Yes, exactly. Yeah.
Did not breathe.
No, the fanny packs were essential though, obviously. Yeah. Yeah.
These are just some more pictures of kind of the site. So the one on the right is our dorm. I think CU donated some money, and so it's, I forget the name. It's like something like the Buffs door. Yeah, the Buffs house or something like that.
Of course.
And then the other side is from the dormitory, looking back towards the clinic and those buildings. The red vehicles are the little tuk-tuks.
Great. Here's the actual clinic. And so again, like that like open space that we talked about. The rooms are inside. Doors are usually kept open because it was just like sweltering hot, like inside the rooms. But like not super close to the nearest hospital. And so, and like especially in like a lot of the roads there, it's like single lane, like each way. And so like pretty difficult for like an ambulance to like actually get to the like city quickly. It's about like 20-ish miles from the like the secondary hospital in Coatepeque, and the tertiary hospital is about, I did the math earlier, like 160 miles away. Yeah, exactly. Yeah, on a good day. And then visited the clinic. It's only like $5, which is like a lot more affordable for the patients who are working either in the community or on the plantation, compared to like a $25 visit, which is a lot more expensive for the patients. Also, like being able to go to the actual like the regional hospital, which is not always easy to get to, and also like not being able to work that day. there, like, we had a lot of point of care tests and services we were able to provide in the actual clinic, but things like, if we had to get like ultrasounds or other imaging, a lot of people would have to go to that regional hospital to get those services. And then we'd be able to like, bring them back and then look at the images with them and go over it with them in the afternoon was
Yeah.
generally how that worked.
Actual x-rays, which we had
Yeah.
never really had much experience, but patients would bring their films and we'd be like, yeah, I think it was something like 90% of the cost for labs, medications, and the visit is covered in part by the funding from the Agro-America partnership, like Nick mentioned. As part of my rural training, Dr. Burke, this felt very similar to when we see patients in Fort Morgan and you have to convince them, it's really important for you. I know it's a far distance, but, we are limited in terms of the services we can offer here. Because patients, are just distrustful. It's hard for transportation reasons. It's hard for them to take off work and the money cost. And so they really want to get as much care as possible. So we really, tried to do as much as we could in the clinic. But, sometimes we didn't have an X-ray machine, but we did have basic blood work, urine testing, stool testing at the clinic.
Yeah.
Yep.
Yeah. And so like really being thoughtful about the test you're ordering, it's I think there's a luxury here where it's, like ordering an ultrasound is not going to like bankrupt the patient. But like here, it's like, it's a pretty big deal to like order these tests for these patients and making sure like you're actually ordering something that's going to change your management. Being really thoughtful about that is another just added layer of complexity to the care. The staff there, like truly wonderful people. On the bottom left picture is like the pediatrician who was working there, as well as some of the nurses and the medical assistants. The other person in scrubs was a internal medicine resident who came with us as part of the rotation. This is another. They threw us a little like going away party. It was so sweet, so that was really lovely. And then on the top right is Dr. Tony Bolaños, who's the clinic director there, who is just like this universally beloved by the community there for like all the services that he's provided. And yeah, it's like really wonderful people there. That water cooler is the only one that actually cools water. And I realized that like the last week of the rotation, which was missed opportunity. Yeah, it's unfortunate.
Yeah, and for context, the lower left picture is sort of our open air like dock box area. So that's where we would sort of hang out. The medical assistants and nurses would sort of brief us on the patients. If we had questions, Dr. Bolaños was really helpful, especially when we were like, dengue, like what's that? There wasn't really, there wasn't Wi-Fi in the area. So also, sometimes when we didn't always have up-to-date readily accessible. So using an actual physical person resource was definitely really helpful. And sometimes, we both knew Spanish, but sometimes just the dialects were slightly different too. So he was a really great resource for help with that. And again, in the lower right, there's also a dental hygienist, a dentist there. Who else is in that picture? Yeah, and then some of the other staff.
Oh, the resident there, like the local like medicine resident was with us as well.
Yeah.
Here's the pharmacy, also air conditioned, really nice. And so it was like really interesting, like the differences in medications in Guatemala compared to here. I mean, it's a lot of like the same like generic stuff. A lot of combination medicines were super common in Guatemala. They really, this is so bizarre. I've never seen so many medicines put into one pill, but they for some reason that was really popular there. But yeah, I mean, pretty good supply overall of things. I mean, we could write prescriptions. They would be able to purchase them in the pharmacy on site for like a discounted rate. But still that like was too expensive for some patients. And so we had a bunch of free samples we were able to give out as well. Again, trying to be thoughtful about like, is this medicine actually going to help the patient? A lot of differences in like what kind of things like people are like willing to treat. And so like things like hypertension, diabetes, I mean, just like a lot of chronic conditions are just not managed quite as aggressively. Just like didn't have as much focus there about treating. Seeing a lot more like issues with like MSK, like complaints with people coming in, especially working like really physically demanding conditions on the plantation. So we had a lot of people coming in for things like that. A lot fewer patients coming in for like hypertension follow-up.
Mm-hmm. Yeah, I don't think we saw really any patients on statins because it was just like an additional expense for something very far down the line. Hard to convince people to go for that. There are a lot of oral rehydration solutions for kids there, especially for like the malnutrition, dehydration, a lot more antibiotics, antifungals, antiparasitics, things like that, that we treated. I'm trying to think of any other big differences.
Yeah. And the pharmacy is pretty easy to buy whatever medicine you want without a prescription, and like in
Other
the-
pharmacies.
Yeah, sorry, other, and then like in the like the
Community.
city, really unclear. Like, I mean, there was a person staffing it, unclear, like pharmacy tech versus like pharmacist, wouldn't generally need a prescription to buy many other medicines. And so we'd have a lot of patients come to us saying like, oh, I've been taking this. And, you know, this like then just kind of assuming that was the right medicine to take for whatever condition they're coming in with. So it was a lot of like us trying to figure out like, you know, like the like Spanish term for the medicine, trying to figure out like what they're actually taking and how long they've been taking it, and like without the advice of a doctor. Because a lot of times like people, there's a pretty big incentive to trying to solve the problem without coming to the clinic, again, for all the reasons of like missing out wages, and, you know, and coming to the clinic is really difficult. And a lot of other more like cultural remedies as well that you would see.
Yeah, they seemed, I think like pharmacies are pretty unregulated there. So, you know, it would often just be like a shopkeeper who had medicines and they would go to him and say like, hey, my kid is sick. And they would just like give them a medicine. You know, in the community, I saw like an infant who I think was like 6 or 7 months old who had a cough. And of course, the mom went to the pharmacy, bought something, and it was like a combination antihistamine, cough suppressant, like Tylenol, and had something else, like very much like dosed for an adult, like just like very alarming. But it also gave me a lot better perspective coming back here with like so many of my patients who are from, you know, this region, from Mexico, are so used to being able to just buy things over the counter, and are like, well, why can't you just give me this? Like, it's just like very normal to get antibiotics, you know, willy-nilly. And like, we have such just like a different culture here and different regulations. So it gave me a lot better understanding coming back here and like talking with our patients, and how so many patients are like, oh, well, I brought this from Mexico, so like that's what I've been taking, because it's just very normal and it's a lot easier. And like Nick said, like, you know, if you don't need to see a doctor and pay for that and take all that time, like, why wouldn't you? So yeah, definitely eye-opening. And I got some acetazolamide for altitude sickness, so I might have used that system slightly.
And she did great. Yeah.
We just have Dr. Bolaños was really interested in taking pictures of us in portrait mode, taking care of patients. So he was very
That's
generous.
pretty good. A lot of that.
Yeah. Just an example of, you know, patients who didn't really want to seek care elsewhere. We had a guy, I think he worked in like a machine shop. His hand got caught in like a pulley. So he had a pretty big laceration and likely a dislocation fracture. He didn't really want to go elsewhere, so I was kind of stitching him up, and that's a splint that I fashioned out of a popsicle and a just some like ace wrap. I think we've finally convinced him to go get an x-ray, but of course he drove like a manual, so he was going to use that same hand to drive like 4 hours to the nearest hospital, but gotta do what you gotta do.
I removed a toenail. They were so impressed by me. It's pretty with like none of the right supplies, but we got it off. It worked well. Yeah, and then a lot of the patients would bring their family as well. It was like a very, very common to have like several family members in the room with us, which I think like sometimes in clinics here, like I really wish like they had more family in the room, you know. And so that was like that was, you know, certainly a plus of it be so like family oriented in this community.
You can't really tell, but in these visits, it's like maybe 105, 110 degrees with 90% humidity. Right. Oh. These are just some examples of like, again, given our age, we've never really used paper medical records that much. So that was the learning experience for us. So, you know, on the left, those were our ways to order labs. It had like a carbon copy. It took a little bit of time to just figure out the difference with the Spanish. And then the patients would take that, go to the laboratory. Most patients, just given the distance they had to travel, they would come to the clinic in the morning, get their appointment, and then they would just wait for the afternoon because we could get the labs back by the afternoon. So then we would just kind of discuss the follow-up plan for them. And they would be able to say if they were in the community or the plantation worker, and that kind of depended on, again, like sort of their insurance or the cost sharing. But, you know, we could get CBCs, we could get urine studies. There were a lot of stool studies, again, because of all the like parasitic disease and stuff like that. So we did a lot more stool studies than I'm used to ordering. H. pylori. Yeah. The picture on the right is just like how our results would come back. So again, that was sort of a learning experience. And then the picture in the middle is when we went to a local hospital. Nick spent time in the medicine ward. I went to the labor and delivery ward. So again, that was just kind of like, that's how they, I think that was like fetal biometry
Ultrasound, yeah.
and ultrasound, like an NST form.
This is where we lived, was the casita. It's like the room on the left. That's everything. I mean, it's the bathroom. There's like a air conditioner in the room, which was a great surprise for me. I was like very happy about that. There's a kitchen as well that's fully staffed. They provided 3 meals a day for us, which is really lovely, and then 1 meal a day for the workers on site as well. And then this is my room on the right, with the cat that lived on. You go ahead, please. This is Pancho. I insisted on having the slides. I'm sorry about that, but Panchito was a big part of my rotation, so I had to include him. Yeah.
Yeah.
Looking fabulous as ever.
There were like a good number of community resources that have been provided and built up by the clinic and different people who have been working there over the years. When we were there was actually a med student from CU who was going into peds and adolescents. Psych residency. And so he was also doing a project on adolescent psych, kind of trying to do like screenings in the local schools, and had developed like a pamphlet about different mental health resources. Culturally, and just given the availability of resources there, mental health, emotional health is very stigmatized, not something that's talked about. And so this was just kind of an example of a pamphlet that he had made and was giving out. One of the other, like my personal favorite community resources was Creciendo Sanos, which had a maternal and a infant arm that involved the community health workers, the nurses, doing home visits for pregnant moms, pregnant people, and then the infants after birth, I think after up to like 1 or 2 years old. And so this has really helped increase screenings during pregnancy, especially for anemia conditions like preeclampsia, to encourage women to actually get screening ultrasounds, anatomy ultrasounds. And home births are really common there, with things called women called comedrones, which are like community kind of lay midwives. Given the high risks around birth, there's been sort of an encouragement of trying to have more deliveries in hospitals or medical settings. And then with the pediatric visits, they do those in the community as well. They provide anti-parasite medicines. They provide different like nutritional supplements. They're there to answer parents' questions about my kid's sick, like what can I give them, things like that. And so it was really interesting to just see all the work that they do, the trust that these nurses have with the community. They've developed entire education materials for people who aren't able to read. So that was really just amazing. And with all these home visits, everything they're doing doesn't have electricity. So to just see the kind of innovation that they're able to do with weights, with blood pressure cuffs, with a urine dip. They had an iPad for education. It just was really amazing to see like how much and how resourceful they were able to be with, pretty limited supplies. And with these, we took the tuk-tuks out into the community, because most people, live in kind of like concrete houses, tin roofs, dirt floors. So some could be quite difficult to get to. This is just an example. One of the nurses was actually pregnant, and they had recently gotten a butterfly ultrasound because their large machine had broken. So we were training on how to kind of just do just little like dating scans with a butterfly ultrasound. So we didn't realize it needs Wi-Fi, so using it in the community was a bit of a issue. These are just some pictures of like the local village, like community called Chiquirines. This is just sort of an example of like one of the main roads, a family that we were working with. Very common for people to live alongside their animals, so pigs, cats, goats, dogs. Hence the increased risk of like infectious diseases. And then the pictures on the bottom, that's the new brand fancy highway that's paved with one of the tuk-tuks on it.
Then able to celebrate the 10-year anniversary of the Trifinio site, which is really amazing. And again, like the Dr. Tony Bolaños there, like accepting an award and just giving like a really beautiful speech about like all the help that and like just really crediting all the workers in the site for all that they do. And it was really like just so wonderful for us to be there, just like coincidentally for the 10-year anniversary. It was really lovely. And we also lucky we were there for Semana Santa, which is like the week before Easter, and so we were able to see like in the Antigua, which is like this like kind of colonial like city nearby, with a ton of history. It's like all these like beautiful art displays of people putting out all these flowers and these like beautiful decorations, and a ton of different like processions through the streets to celebrate. So it was like really fun to be there during that time. And then just picture the food. You can probably tell which one's Johanna's because it's way better than mine picture. But yeah, it was like a lot of like plantains, beans, like fresh cheeses and tortillas and eggs, stuff like that. So it was like really wonderful food.
Yeah, the women who cooked for us at the dorm, one was like a very well-trained chef. She made these beautiful pastries for us. You know, they made fresh tortillas by hand every day. Like it was just, food was one of the highlights of being there. It was absolutely incredible to just like experience this, and they were so lovely.
Mhm. We just have some reflections and we'll leave some time for questions at the end. So, you know, this is again, like really accessible and a lot more affordable primary urgent care for this population that otherwise would be really challenging for them to receive it. And so it's like a really strong connection between the clinic and just the like the population, the community nearby. And they have a lot of trust in their physicians. You know, it's like I mean, like two white people who like Spanish is their second language and trying to give advice to patients is like definitely didn't land as well as Dr. Bolaños, who's been deeply entrenched in that community for a lot longer, giving that advice and like better Spanish than we can speak. And so definitely like understanding that like some of the limitations of like what we could provide to the people there. And like Johanna was saying, Will, the medical student, was, like, he did a really interesting study and just understanding the resources that are available for mental health and just the perceptions of what mental health, like using words like stress instead of anxiety, things like that. So that would be a lot more, that would go over culturally better for patients because a lot of somatic manifestations of mental health, like mental illness, like within our patients, and again, like how to address that in a culturally appropriate way was difficult to learn. Yeah.
I think one thing that we reflected on that we were really grateful was how our program and concentration did this very intentionally, like having the pre-work, learning about the country, learning about kind of cultural differences, things the country has struggled with. It's a very Catholic country. LGBTQ issues are kind of, a hot topic. Domestic violence is high. It was really helpful kind of knowing about that coming in just to be able to better understand, talk to our patients, as well as, to approach this more from like we're here to learn from them, not like we're here to, help and volunteer. We were able to learn a lot more about tropical diseases than we knew before, and dengue in particular, as well as to just like, see a really strong community health model that, is something that I think they are a much stronger version than we do. Was really impressive to see how they're able to do that and how they're able to do so much with fewer resources than we have here, as well as just like the level of trust they have in those partnerships. And then we kind of already talked about it, but just having a better understanding of, so many of our patients come from similar areas with cultural differences around prescribing practices, medications, and medical care in general, and just having a better understanding of that, appreciation for that, for my own visits, I found really helpful.
Mhm.
And I think, yeah. So yeah.
Yeah. What questions can we answer?
A month. Mhm. And so I wondered about whether you all had considered or were active in the approach of or
Ooh, good question. Didn't, no, not much of a preference, no. The food was off, I think generally outside, and so, yeah, I enjoyed that, yeah. Yes, yeah. Did enjoy the rooms with the beds, though.
Yeah. He enjoyed the pets.
Yeah, yes, wherever they were.
How is the how is the program funded? In Guatemala, well, both.
So my understanding, correct me if I have some of this wrong, most of this is funded by some of the agriculture companies that, it's their workers on that plantation. So the Fund Salud is like the Fundación Salud there, and it's a lot of them coming together to support this effort. And then my understanding is there is some funding from the CU Center for Global Health as well. Do you guys know about anything else?
Yeah, that's
Yeah,
kind of my understanding
yeah.
as well. And we would be remiss if we didn't also thank our program directors and our staff who really scrambled at the last minute to help approve all the necessary documents to let us go on this rotation, because there was some snafus, but we're very thankful that we were allowed to go.
Thank you for acknowledging that. I actually have, I have some red ink in my calendar for that day. But the question is residents are paid, and in a very roundabout way, by the federal government. And so they aren't allowed to be paid during their time out of the country. And, Johanna's salary actually comes in a roundabout way through a state grant, but the university sort of gives us dispensation and allows their salaries to continue, even though the usual funding streams are disrupted. So could you?
Any other questions in person or online? No? Well, thank you all so much for sharing your experience, for the context setting when it came to the program itself. We're so grateful that you were here. This was really enriching, and I'm a huge fan of anything that features a cat. So
Of course.
thanks for everything you do.
Yeah, thank you.